Welcome to today's Student Athlete Educational Series presented by York SAC and the Student Athlete Success Program. The topic for this session will be facts and myths about the COVID-19 vaccine. We are pleased to be joined by our very own York College team physician, Dr. Ariel Nassim, a former CUNY tennis player at Queen's College. Dr. Nassim has a wealth of experience in the field of sports medicine, having provided his services to the USTA and the US Olympic teams, to name a few. I'm delighted to welcome Dr. Ariel Nassim. So thanks for joining us today, Dr. Nassim. I'll let you take it away with the presentation.
Thanks for having me, Amy, and honored to be a part of this. Let's just pull up the PowerPoint here. So we will be taking questions at the end, so I'm happy to field any of those as they come up, and we can have a nice discussion after, perhaps. So talking briefly about some of the COVID-19 vaccines, but before that, we'll go through some of what COVID-19 is and some of the treatments and various things about COVID-19 in general. As Amy has said, I've been the team physician for York College Athletics for the last couple of years, and it's been an honor to do so. As she also mentioned, I was a CUNY athlete myself, so I kind of have been in your shoes, and I know where you're all coming from. So it's a little something about COVID-19. So we turned into a pandemic last March. So a pandemic is essentially an epidemic of disease that spreads across the country, across multiple countries and continents. For instance, the Spanish flu from 1918 to 1920 infected over 500 million people back then and killed over 50 million. Obviously, modern medicine was not what it was today. And, there was a very high incidence of death with that. Swine flu, which we did encounter just about 11 or 12 years ago, infected about up to 20% of the world's population. Really did not kill as much as COVID-19, and that's why some of us don't remember it as a very deadly virus, but there were still 500,000 people that died from that. And then in December 2019, there was a virus isolated in Wuhan, China, that was causing a mysterious illness, a respiratory virus, and within a couple of months spread to multiple parts of the world. And that's really where the World Health Organization declared a pandemic last March. And many of us remember that day. And it was likely to create a pandemic leading to multiple deaths across the world. So the name of the virus, many of you, if you've been tested for COVID, you see SARS-CoV-2. That's because we had a SARS-CoV-1 about 20 years ago in Asia. That did not spread like this current COVID infection has spread. So that was the first one that we saw 20 years ago, really was contained, and the current pandemic is caused by SARS-CoV-2, which is a severe acute respiratory syndrome coronavirus 2. Really, COVID-19 is the name they've given for the disease caused by that virus. So there are many viruses. The common flu is a virus. And again, COVID-19 is the disease that we see caused by this new virus that's come about since December of 2019. So to put into context, this is data from about 2 days ago that's most up to date. Globally, we've had just under 140 million cases of COVID-19. There have been just under 3 million deaths from COVID-19 thus far. Obviously, that's still going on. We are not past this pandemic yet. In the US alone, we're over 30 million cases and over 500,000 deaths just in our country. And realize it's just over 1 year. So those are numbers within the first year. Will likely go up over the coming months as well. Thankfully, not as fast as it has gone up in the preceding 1 year. So what are symptoms of COVID-19? So common symptoms you can see here: fever, dry cough, body aches, fatigue, loss of sense of taste and smell is very common, especially in younger populations. Headache, congestion, sore throats. Some people have diarrhea or abdominal pains as well. The thing to realize is that these are symptoms many people experience for a variety of reasons. So not all of these means you have COVID-19, but if you're experiencing any of these, it's a reason to contact your physician, discuss what your symptoms are, and see if it's worth getting tested for COVID-19. Really, what I tell people is early identification is the most important thing. People do fairly well with COVID-19 if they recognize it early and they treat it early. If you kind of ignore symptoms for a period of time, go 1 week, 2 weeks, and still having symptoms without getting checked out, very often that's where we run into some issues. What are some more severe symptoms of COVID-19 or some of the complications? People can have chest pain, shortness of breath. There have been multiple reports of stroke and heart attacks, as well as other blood clots that occur with COVID-19. Again, these are not common, but these are potential complications from the virus and the reaction to the virus. There have been individuals with organ failure, respiratory failure, pneumonia, and then in rare cases, there have been reports of multi-organ inflammatory syndromes that they saw in children. Again, I want to emphasize most children do not get very sick from this virus, but there have been reports that some may develop this inflammatory process that goes on. So the great majority, I should say, have mild symptoms, like a common cold, essentially, and most people improve without any treatment anyway. There are some people who are asymptomatic. Early on, they were reporting asymptomatic spreading of the virus. And that goes on to say why it's so important to wear masks, even when you're feeling fine. It's not only if you're coughing that you should have a mask on. It's the idea that we could be carrying this virus and spreading it asymptomatically with no symptoms. And therefore, that's an important reason to keep those masks going, at least for the time being, until we hit some sort of herd immunity. And we know people around us are safe. Severe symptoms often need hospitalization. We were discussing earlier, we know a lot more now than we did 1 year ago. So, in New York, we felt it hardest, most likely, as opposed to the rest of the country. Other parts of the country had waves that came on and got hit harder later in the pandemic, but we were the first ones, and we really were in the dark. The doctors did not know what was going on in terms of how to treat this best in the early stages. And we've come such a long way in a very short period of time. So even those with severe symptoms, if they're seeking treatment early enough, we could get them treatments that do help and do hopefully help prevent the need for intubation, mechanical ventilation, where we breathe with a machine for the patient instead, and hopefully avoid deaths that are preventable. Risk factors for severe illness, elderly is probably the highest on the list. The older the age, the higher the risk for more severe illness. High blood pressure, diabetes, obesity have all been recognized as risk factors. So there's many people that are, aren't getting these treated well or haven't realized that they have these underlying conditions. Also highlighting the importance of seeking regular care with your physicians, and a lot of your family members, perhaps, as most of you are college age, so you're not dealing with many of these issues. But if you have family members who haven't seen the doctor lately, that's an important reason to get in, identify those risk factors or anything that might be going on. If the sugar is high, the blood pressure is high, and get those treated before they get sick, because that does make a difference with how that illness goes for them. In terms of treatment options or prevention of severe illness, so there's multiple things out there right now. I would say of all the treatments we have, the best one is really what we call monoclonal antibodies. And that's something that's been developed since the beginning of the pandemic, where they're giving essentially antibodies to a patient who has not seen the virus before, but now is sick with the virus. They have to be given it within the first 10 days of their illness. And it's only certain groups that qualify right now. That there's not an unlimited supply of this. So they do have to allocate it more to those higher risk categories, many of which fall into what we just discussed on the previous slide. But I will say, asthmatics, anyone with asthma who takes a daily inhaler qualifies to get this. Anyone, again, high blood pressure, morbid obesity, age over 65. And there's some other indications as well I didn't put here, but for the most part, this is another reason why it's so important to identify the illness early. If someone's not feeling well, get tested right away, because if they test positive, their physician may figure out if they qualify or not to get this treatment that prevents people from getting worse. This is not a treatment if someone's already in severe illness. If someone's already developed pneumonia, there's other treatments. This is the one thing we've seen that really prevents people from getting to that severe stage and is most effective early on. So if someone has symptoms, they get tested immediately. If they get this in the first 3 days, from my experience, within 48 to 72 hours, their symptoms are almost entirely gone. So really, I would take this as one of the take-home points of what's most important as a possible treatment option that not a lot of people realize is available. In terms of other things, vitamin D, there have been multiple studies showing vitamin D helps in terms of preventing severe illness. Vitamin C and zinc are very important for immune health. And there's just a study published this week talking about how regular exercise has been shown to prevent severe COVID-19 infections. So hopefully all of you have been keeping up with your exercise, but if not, it's a good time to get back on it, as it might be a good way to prevent severe illness. I wrote remdesivir and steroids on this slide because remdesivir is an intravenous medication we give for patients with more severe illness, usually with pneumonia, that are hospitalized. And then steroids is also something we've used for hospitalized patients, as well as some patients that haven't been hospitalized that have persistent symptoms that have been going on for some time. Anticoagulation is blood thinners. As I mentioned earlier on, some of these patients are at risk of developing blood clots, and that's where blood thinners come into play to help treat those blood clots or sometimes to prevent them. And then the last thing is really vaccination. And this is, one of the success stories of the last 12 months is, what normally takes 10 or 15 or 20 years to develop a vaccine, we've been able to develop in a very short period of time. And not only develop it, but develop a vaccine that's highly effective and safe. So right now I listed all three. As some of you may have heard this week, the Johnson & Johnson vaccine is on hold in the US. We have two other ones that have been approved in the US for use. It's the Pfizer and the Mrna Vaccines. Again, so Pfizer has been approved for anyone over the age of 16. It's two shots to the arm, 3 weeks apart. And then the Mrna is anyone over 18 years old can qualify. And it's 2 shots 4 weeks apart. And again, it usually takes 2 weeks after the second shot to recognize that full immunity. That's what they've found. Johnson & Johnson was initially approved under emergency use. And obviously, they continue to study all of these vaccines for a period of time after they've been released. And what they saw was there was a few cases of unusual blood clots in some patients, and I'll get to that in a future slide. But and that's why they put it on hold, because they really did want to investigate that and see, is this more chance or was this related to the vaccine potentially? So to explain some of what goes on behind at least Moderna and Pfizer's vaccine, these are a new class of vaccines. In the past, vaccines took either a live virus that was dulled down or a piece of a dead virus and injected into us, and our bodies developed a reaction to it to help us fight future infections related to that. mRNA vaccines are a new type that really help us fight those infectious diseases, but it's done differently. We're not putting a piece of the virus in us. The mRNA vaccine really is injected into our bodies. It teaches our body to make a protein that's on the virus itself. And that's when our immune system builds antibodies to fight that piece of the protein, so that when our body gets exposed to the virus that has that protein, now we can suddenly recognize it, our body can fight it, and we don't get ill, or at least not severely ill. Benefits of these mRNA vaccines, like all vaccines, is protecting patients so that we don't get very sick when we get the virus. So again, this kind of goes through that a little bit. This is a nice slide because it goes piece by piece in terms of how it works. So the first step, the vaccine is given, the Pfizer or the Moderna is given in the arm. the instructions that mRNA goes inside of our immune cells. The cells then make the protein piece. After that protein piece is made, the cells break down the instructions and get rid of them. So those instructions, that mRNA vaccine is gone after it's created that. Next, the cell displays the protein piece on the surface. Our immune systems get ramped up as it recognizes a protein that doesn't belong there. And that's exactly how our bodies develop antibodies to those proteins. At the end of the process, our bodies learned how to protect us from a future exposure to that virus. As we learn about mutations, many of us hear about mutations. We have South African variant, the Brazilian variants. These are all mutations they've seen that come from different parts of the world. And as the pandemic moves on, we may see more and more of those. Those are changes in certain proteins on the outside of the virus itself. So what we recognize is that, there may be a time if we find that Pfizer and Moderna no longer are effective for certain variants, they might be able to create an mRNA vaccine specific for those spike proteins. And that would be like essentially a booster shot for us to protect against those variants as well. So what are some facts about COVID-19? The mRNA vaccines, they do not use any live virus. So someone cannot get sick from getting one of these viruses. There is no live COVID-19 in any of these viruses, in the vaccines. They do not in any way affect our DNA. Some people were talking about how mRNA goes in and changes our DNA. That's not the way it works. It never enters the nucleus of the cell where the DNA and the genetic material of our bodies is made up. And the cells break down and get rid of the mRNA as soon as it's finished using the instructions in this one instance. So those are some things that we often hear about. There's a lot of misinformation out there, and I think it's important to, correct people when they make the wrong assumptions about these vaccines. So who should not get vaccinated, at least from the mRNA vaccines? Anyone who's having a severe allergic reaction, or even if it was not severe, anyone who's allergic to any of the ingredients in the COVID-19 vaccines, anyone who after getting the first shot got an allergic reaction should not get the second shot either. And then again, an allergic reaction is considered anyone who was treated with an EpiPen or was told to go to the hospital after they got the vaccine. So mRNA vaccines in general are safe, effective, and reduce the chance of severe illness. We have 2 of them approved under emergency use right now in the United States. Amazingly, you're talking about 90 to 95% effective at reducing severe illness and approximately 100% effective at reducing death from these viruses. These are incredible numbers considering the yearly flu vaccine that many of us get on a good year is about 70% effective. So we have to recognize these are very, very effective vaccines. And as I mentioned earlier, as they've been giving these, there have been over 30 million of these vaccines given so far. They continue to watch to see if anything comes up in terms of adverse events, anything dangerous going on. And both of these have held up the test of time so far. Most adverse events from vaccines we see in the first 3 months, these have already been being studied since last summer. So we're talking about going on 9 months or so of data that they're looking at. And again, millions and millions of patients. So what are normal vaccine side effects? There's pain, redness, swelling in the injected arm. Those are very common. I got the Mrna vaccine just because that was what was offered to me. I can tell you after the first vaccine I got, I certainly had about a day and a half of soreness in my arm. So if you have a big tennis match, probably not a good idea right before. But you might want to time this at a time when it would be okay to have a sore arm. Again, other things that you might experience: fatigue, headaches, muscle pain. Some people do develop fevers for a few days as well. And these are normal side effects to the vaccine. These don't mean you're having an adverse event. They're actually a good sign. It tells us that your body is creating an immune response, creating antibodies so that you can fight a future infection. And again, the majority of these effects subside within 2 to 3 days. to talk a little bit about Johnson & Johnson, this is a viral vector vaccine. So that's when there's a piece of the virus, not a live virus, but a piece of the virus that was injected into the body. The body creates an immune response, more similar to traditional vaccines that we're aware of. In clinical trials, the Johnson & Johnson was about 66% effective at preventing illness. And again, a high efficacy at preventing hospitalization and death. So even with Johnson & Johnson, it really did limit, it did prevent hospitalization and death in a great majority of those patients. What happened with Johnson & Johnson, it was released under emergency use. We had about 6 million doses given in the US at least, when there was about 6 reports of unusual blood clots, something called thrombotic thrombocytopenia. And it's currently on hold just because the FDA is really investigating to see whether these truly are vaccine related or not. I want to remind people, this is why they continue to study these. So I'm happy that it's on hold. We have to let them go through everything they need to go through to figure out if this is truly something to pull this off the market or not. But realize there's 6 cases in 6 million doses given. You're still talking about a 1 in a million chance of a rare event happening. The chances of hospitalization from COVID-19 itself are much, much higher than that. Even when you go into a healthy young population, I myself have had numerous 25 and 30-year-olds who are otherwise healthy in the hospital for 5 to 6 days because of this virus. So, the chances of getting very sick from this are way higher than that 1 in a million of a rare side effect. Nonetheless, it's on the FDA to really investigate this and see if they truly are going to continue using it or not. Future vaccines, AstraZeneca, also on hold in Europe. It's not approved in this country at this moment. They're currently investigating reported blood clots from that vaccine as well. And there's a Novavax vaccine also in stage 3 trials here. So we'll wait and see. There's various different vaccines throughout the world right now. Different countries are using different vaccines. I would say our country is ahead of the game in terms of being able to vaccinate a big part of our population. So why get vaccinated, right? So a lot of people come to me and say, well, I'm young and healthy. Why do I need it? I'll just get the virus and roll the dice. And that's true, potentially. But you have to realize you also have to protect the people around you. Many of us have elderly family members at home, and the vaccines, we got to wait and see if we really prevent transmission of the virus. But from what we're seeing is that there might be a decreased transmission of the virus as well. So if you have elderly family members at home, anyone in a high risk category at home, you have teammates, coaches, athletic training staff, there's a lot of people we're interacting with on a daily basis that it's our duty to really try to protect them. And that happens with not acting irresponsibly with our interactions, continuing with masks, using good hand hygiene, but vaccination does play into that as well. Other thing, lowering the strain on hospitals and healthcare systems. Our healthcare system in New York was really pushed to the brink last March and April. So we don't want something like that happening again. Thankfully, our hospitals are doing well right now. Our numbers are down in terms of COVID hospitalizations. So I'm hoping that only continues to go down, but realize these are our actions impact all of the people around us and really the society around us. So we have to be aware of that. And then the last thing is really protecting yourself. Like I mentioned, vaccine adverse events are very rare. Risk of hospitalization is higher than the risk of those adverse events. And we have to keep that in mind, that there is a greater good in all this. And again, the more people are vaccinated, the sooner we'll get this pandemic behind us. So we all want to get back to normal. And we all remember what last February and last January were. We don't want to stay in what we're in right now. So we really want to do our best, work together to get through this safely, keep everyone around us safe, and hopefully have a good season next year when we're all playing sports together again. And this is a nice picture of me and Amy. So I thank everyone for your time. Happy to take any questions that you might have.
Thanks, Dr. Nassim. If anybody has any questions, feel free to ask him right now, or you can put them in the chat. I'll open it up to you guys. I also have a few questions to ask, but I'll open the floor up to some people and see if we can get some questions.
Yes, this is Coach Titus, Women's Volleyball Team. Question, once a person takes a vaccine, do they have to take a booster shot every year?
Can you repeat that? Sorry.
Once a person takes the vaccine, do they have to take a booster shot every year, like the flu?
You know, it's hard to tell. As we see the virus change and mutate, we may need booster vaccines. I think a lot of it depends on what's going on in the world. You know, if these are highly effective vaccines and a huge portion of our population is vaccinated to the point that this virus is almost gone or at a very, very low level, we may not need those booster vaccines. But if we allow the virus to kind of remain at a high enough level where we're going to develop mutations, then yeah, we're going to need vaccines to it. We're going to need booster shots on an annual basis. But I think a lot of that we'll find out probably in the fall, probably in the winter of next year. If we see a great majority of the virus infections are really not covered with the previous vaccine, then we'll need the booster. If we see that, you know, the protection, it hasn't mutated, but the protection from the virus weans, and after about 1 year, we don't have any of that immunity or any of those antibodies anymore, certainly we'll need a booster. But I think that's one of those things that time will tell us more than anything else. Anyone who tells you that right now is probably a little premature because we don't know. We don't even know how long this vaccine will last. We don't know if you'll have immunity from this vaccine 2 years, 3 years. You know, we get vaccinated as children and infants. We don't get a lot of booster shots on many of those vaccines. So it's hard to tell if this is going to be something that's a once or twice and we're done, or if there's a booster that comes down the road.
So we're saying it's based on a mutation, just like how HIV has mutated, have mutated. Can we know with viruses such as HIV and we've seen with coronavirus, we've seen a lot of mutation because coronavirus have been mutated from day one. So,
well, all vaccines, all viruses mutate. Realize even the common flu, every year our flu vaccine changes a little bit to attack the previous year's mutations that they saw. What I'm saying is that it depends a little bit on those mutations, if it mutates. And it also depends on, does the vaccine continue to last? Does the immunity in our body, those antibodies, last for a period of time that will continue, or do they wean off where we need a booster shot on that same virus particle as before? You know, those are two different sides of this. And all viruses mutate, but it doesn't mean the vaccine is ineffective. You know, if it mutates, but those proteins are still on it, we may still be able to attack it with the antibodies we had from a previous vaccine. HIV is a little bit different because HIV is a very unique virus. You know, HIV essentially goes in and changes essentially the genetic material of the virus in the body. So it's a different type of virus. It's a retrovirus. So that's, you know, a long conversation for another talk, but HIV is a little bit different. That's probably why they haven't been able to develop a vaccine for it. But if we look at most of the other viruses that we've seen, we've been able to develop successful vaccines for it.
Thanks, Titus, for your question. Sorry. Okay, there's a question in the chat from Genera. Are the symptoms the same for all ages? For example, the elderly, since their immune system is not that strong. Genera, are you talking about symptoms from the vaccine, or are you talking about symptoms from the virus itself? Let's see if we get clarification. I'm assuming she's talking about symptoms from the virus itself.
Yeah, I think she's talking about that, but we'll address both actually. So in terms of the symptoms from the vaccine, if that's what you're talking about, we do find that the higher the age, sometimes their response to the vaccine is not as robust. You know, someone with a young, healthy immune system might actually get more severe symptoms after the vaccine. And that just means their immune system is ramped up and really working to build more antibodies. As the age goes up, the immune system is a little weaker, it has more age on it. So what we find is that there's not as robust of that immune response. So that's why you hear some elderly that say, oh, I was fine after the vaccine. It tells us that there's also probably not as good of an immune response, so they may not be as protected as much as everyone else. So it's still why we have to keep a close eye on them. I had a few patients who got vaccinated. They were 80 years old, got vaccinated, still got the virus. Luckily didn't get very sick, which is kind of the point of the vaccine, is so they don't get very sick when they get the virus, but they can still get the virus. Realize that the point of this is so people don't get very sick. If everyone gets the virus, but everyone has a very, very mild cold, we've got plenty of viruses like that. We have rhinovirus. We've got plenty of every year viruses that don't cause people to get hospitalized or die. And if we can get to that point with a vaccine, that's only going to get us to a better place.
Great. So I'm just going to piggyback on what you just said there about, because one of my questions was, can you still get infected with COVID-19 if you've been fully vaccinated, which you just said, yes, you can. So then my next question is, does the vaccine offer some protection against long COVID? So people who are having prolonged symptoms, is there some science that shows it's helpful for that?
Well, long COVID means they're having long-term symptoms after a COVID infection. And what I would say to that is, I think it's a little too early. Realize we've been vaccinating since January, essentially. So I would say I have not seen anyone who was vaccinated who has long COVID. And I certainly have some patients with long COVID, persistent symptoms for a very long period of time afterwards. So from what I've been seeing anecdotally is that, yes, it prevents. It seems like people with a more severe COVID infection end up with some of those long COVID type symptoms. So the milder the symptoms initially with the virus, the lower the likelihood of having long-term COVID symptoms, which is probably not related to the COVID. It's probably related to, ongoing scar tissue or whatever else has happened from the original infection. But yeah, the milder we get that first infection, the less likely to have long-term problems from this. And the vaccine does seem to help reduce the severity of that initial infection.
Great. I've got a question here from, sorry, go ahead, Titus.
Quick question. Why is it when people test positive for the coronavirus, they say they have COVID? And they might not have no pre-existing condition at all, but just have the virus alone.
Yeah, I think most of it is just the misnomers and how people are calling things.
Yes.
I think the public has gotten so used to just saying COVID, COVID, COVID. Really, you're right. I mean, COVID-19 refers to someone
Diagnosis.
symptomatic with the coronavirus. And, it's also most people testing that come back positive, say they have COVID because they tested for a reason. Now, there's definitely people who are testing when they're not having any symptoms who come back positive. And certainly you can make an argument that that's not truly COVID, but that's more they're infected with coronavirus without having symptoms or asymptomatic. But I think that's more, how we're talking more than anything else. I think people have just gotten accustomed to saying COVID-19 for anyone who tested positive.
And that's what drives the stigma. And that's what drives the stigma around COVID-19 for a lot of people. The language.
Yeah, for sure. Okay, I got a question here from John. Can I come back to you? I'm just going to ask Venus question, and you can pop in next. How does the vaccine affect women? Is it making them infertile or having an effect on allowing them to get pregnant? Since women who are pregnant are not advised to take the vaccine, how do we know in the long run if this affects us?
So a very good question. And, I'll take it piecemeal. Why haven't pregnant women been offered the vaccine, or why are they advised not to get it? I think it's just related to the fact that the FDA didn't have a study or a trial showing it was safe in that population yet. So I think part of why they say don't get it when you're pregnant is because the trial didn't look at it. And currently there are trials looking at pregnant women who get vaccinated and do they have any complications related to that. I think that's part of the science behind this, and why, I'm grateful we live in a country that has, these institutions that study and make sure things are a certain safety before they release it to the public. In terms of the other part of the question with fertility, I think that's one of those things that's floating around that creates some hesitancy. There's nothing to indicate that this causes infertility that we see, and no one has a crystal ball, but I can also say that none of the vaccines prior to this we've seen to cause infertility. No hard science to show that. So again, we have to go based on science. Obviously, science changes, and I can't say we're not going to learn something horrible in 8 months and suddenly we'll recommend no young women should get it, but there's nothing to indicate that will happen. The same way we assume that there's no big side effects that come up with these things, but with Johnson & Johnson, we saw, there's 6 out of 6 million people who develop blood clots that might be related to the vaccine. And if you asked most people 3 weeks ago, they would have said, as far as we know, this is a safe vaccine. But again, I don't suspect we're going to see broad-based infertility. Realize there are many reasons for women to have infertility. More and more infertility clinics are busier and busier now than they've ever been. And I don't know if that has anything to do with vaccines necessarily. There's a number of reasons that might be, but at the same time, someone who's having trouble getting pregnant 12 months from now may look back and say, I got a vaccine and I was having infertility issues. But like I said, there's millions of women who have infertility issues unrelated to vaccines. So again, it's hard to say that it's going to be cause and effect, or is it, if someone has infertility in 12 months, is it just because they likely had some infertility issues to begin with and not related to a vaccine they were getting? There's nothing to indicate any infertility that could arise from these vaccines. Mechanistically, it does not seem likely at all based on how the vaccines work either. So I'm going to say at this time, even to my own family members who are in reproductive age, I've recommended to get the vaccine. So I certainly don't want anyone to have that hesitancy, because there's been nothing to indicate it. Pregnant women, no, I don't recommend getting it, at least until the studies come out and say it's safe and effective during pregnancy. My wife was pregnant and she just gave birth. So we certainly did not vaccinate her during the pregnancy. And then right now she's nursing, but as she finishes up that aspect of, her having a new child, we'll probably get her vaccinated as well.
Yeah, go ahead, John.
Yeah, Dr. Nassim, this is a personal question. Thanks for taking the time out.
Hopefully not too personal. We're on live television here.
No, it's fine. I am scheduled to have the Johnson & Johnson vaccine on June 8th. Now, I haven't heard back from them nor got an email. Is it safe to assume that they're going to go ahead with it, or they're going to just go ahead with the Pfizer or the Moderna?
Yeah, so in New York State, anyone who's scheduled for Johnson & Johnson is going to get a vaccine other than Johnson & Johnson for the time being. It's meaning, so if you had an appointment for tomorrow, you would go there and likely get Pfizer or Moderna, whatever's available at the time. I think a lot has to unfold regarding what's going to happen by June. That's a long time from now.
Yeah.
So certainly, we got to see. They may investigate it and say, you know what, this is within the statistics of how often we see these blood clots, and it was not related to the vaccine, in which case they might reauthorize it and give you the Johnson & Johnson at that point. But anyone scheduled for Johnson & Johnson will get a replacement with the Pfizer or Moderna at this point.
Great. Thanks a lot, Dr. Nassim.
Can I just jump in? I got another question that pertains to the Johnson & Johnson. This is a good opportunity to put that in there. Somebody who's already had the Johnson & Johnson, What would you say to them at this point if they're concerned about any adverse effects? I mean, we just said it's like 6 and 6 million, which there's obviously a higher prevalence of getting a blood clot from things such as birth control at this point. So what would you say to them to sort of allay any fears they may have?
Yeah, so I'd say these blood clots they saw in those 6 individuals happen within the first 2 weeks. So if you're a month out or 6 weeks out from getting Johnson & Johnson, it's unlikely to have anything. If you are within those first 2 weeks and you're developing unusual headaches that aren't going away, if you're developing any unusual sort of blurry vision, dizziness, those are reasons to contact your doctor. Again, many of those things are self-limited and they'll resolve. Some, people get headaches after the vaccine itself. But again, it's anything more unusual that's persistent, that you're not feeling right. If you're bruising easily, if you're having leg swelling, those are reasons to contact your doctor right away or go to the emergency room. But like Amy mentioned, 6 and 6 million, we're talking about very, very rare side effects. Or adverse events. So again, any concerning symptoms, you have to contact your physicians, but it's still very rare. And like Amy said, it's a higher likelihood that you get it in some other fashion from some other cause still.
Question about newborns and infants in terms of our protocol recommendation for immunization for the individual. Should they or will they be getting immunized as a regular, like how they get for the measles and chickenpox and when it comes to newborns and infants at a certain age?
Yeah, I think the studies have not been there. I know Pfizer has started clinical trials on children. I don't think they've started any trials, as far as I know, in infants, but they have started in children. So, this is how they do it. They study it in adults. They released it in adults. At the end of the day, adults are the ones that are really the ones highest at risk. If you look at COVID, it's interesting because this is different than the flu. If you look at the flu, it disproportionately affects young, healthy people, children as well, where you get children with very severe flu infections at times end up hospitalized. You get young adults who are healthy ending up with the flu hospitalized with severe infections. COVID has really affected that elderly or underlying condition population. And it has really spared, for the most part, that younger, healthier population. I'm talking about children, infants. Most children that get it end up having low-grade fevers, mild viral symptoms that are self-resolve within a few days. But as they study this, we'll have to see. By the time they actually get through the trials in children, we may be at a different point in this pandemic, and we may not need to vaccinate all the children. And I think that's going to unfold in the coming months or years even. But certainly the children pose a lower risk population. So I think we certainly have less urgency to try to get them into those clinical trials. But very important is really that adult population that should get vaccinated, that needs to help us get past this, urgent point of the pandemic where we're still seeing high numbers of cases.
I have another quick question.
Sure.
In comparison to tuberculosis transmission, you know that in tuberculosis, we talk about transmission from children to adult is very rare compared to adult to children. So would it be the same thing here, since it's supposed to be kind of an airborne as well? So kids to transmit the virus to an adult?
Right. So again, I think the transmission, we talk about asymptomatic transmission. We find that, people are most contagious when they're actually putting a lot of respiratory droplets in the air. It's probably why you see it more from adults to children in tuberculosis, is because, the elderly, their immune system goes down, tuberculosis becomes active, and that's when they start having more respiratory symptoms. Similarly here, children, sometimes their cough is not as strong to create those big respiratory droplets. Whereas, older individuals, adults, if they're symptomatic and really coughing, they're putting a lot of droplets into the air and are going to become more contagious than others. And that's probably why we find, there's some studies out there in very reputable journals showing there's very, very low transmission rates in children under 8. And that's one of the arguments people make, that, classrooms for children under 8 should really be open. And we're doing a disservice by some of the policies in certain places in terms of how they've kept many of those children out of classrooms. So, there was one study that came out about a month ago that looked, and there was a higher incidence of getting COVID going out in public than there was going to school, meaning that school was probably safer for people to go to than going out in public. So it kind of goes to show us, and obviously there are some nuances to it that we want to look at the ages, but that really does look at some of the younger population. And it tells us we have to keep things into context with all of this.
Okay, one more question here in the chat. I think she's referring to, there's been some media attention on this about how women, when they receive the vaccine, they get swollen nodes, and when they go for their breast exams, it's showing up on breast exams. So I think she says the question is does it cause breast cancer? Is there any effect on causing breast cancer from the vaccination?
So excellent question. So again, the immune system with the vaccine gets ramped up. So what happens is that the lymph nodes in the body can definitely enlarge, because the lymph nodes are where our body fights what it thinks is an infection. So when our immune system is ramped up, we're building antibodies, our lymph nodes enlarge. Many women with breast cancer have cancer that spreads to the lymph nodes under the armpits. So what happens is that some people get enlarged lymph nodes in their armpits, and they think it's concerning, and they go for their mammograms, and it shows up, it lights up. But obviously that could be related to just fighting a vaccine and building an immune response. What we're recommending is for 1 month after, as the last time I checked, it's 1 month, to not have mammograms for that 1 month after the vaccine, because you can get false positives. It can look like these lymph nodes are all enlarged, when in reality it was only related to the vaccine, not related to some sort of underlying cancer. Now, with that said, I've also had people that went, because they had enlarged lymph nodes, had them evaluated, and they picked up the breast cancers. I would say in those scenarios, the vaccine absolutely did not cause breast cancer. What was more likely is that they had an underlying cancer that was dormant that they didn't realize. And this just got them to go to the doctor and get the workup done. And it happened to pick it up. So I know a few people who actually had incidental findings of breast cancer and are getting treated for it, but in some ways might have saved them because they picked it up sooner. But certainly lymph nodes do get enlarged after the vaccines. We do see that. That's part of the immune response. So that's why they are recommending for about 1 month after the vaccine to hold off on any routine imaging. Again, that's not if someone needs urgent imaging, if there's a reason, if they're looking into a certain lump, but it means if you need a routine mammogram, you should probably push it off about 1 month and get it done after that 1 month to make sure you don't get a false positive because lymph nodes are enlarged.
Thank you for that. I've got one more question, and then if no one else has got any more questions, we can wrap it up. But if there's still more questions, obviously we can take them. So what I hear a lot from people, and this goes to friends, my own family, I've had to convince them to get this done, the vaccine done, is that the vaccine hasn't been tested enough. It came too soon, it came too quickly, I don't trust it. Can you speak to the research that's been done on this and how much funding has been actually assigned to this to get it approved, emergency approved, and why we should trust it?
Yeah. I mean, you might know the funding number more if you're asking me that, but I imagine there's billions of dollars that have gone into the funding of these. To give some background, there's a lot of red tape that goes into a lot of this. mRNA vaccines, I know at least have been being researched, studied, developed, probably dating back about 20 years since the SARS viruses. So, these have been things in motion for over 20 years or so. What happened now is we're just plugging in this virus for the development. The other thing that's happened is with the emergency use, the government has taken away a lot of the red tape. So before, what has actually, sat on desks, sat in a lot of bureaucracy in terms of getting approvals for various things, they've sped up the process. They didn't eliminate the process. You know, they still had rigorous trials they had to go through. They still had to prove safety and efficacy. You know, with Pfizer and Moderna, you're talking about 30,000 people that are getting each of these vaccines. And they watched them over a period of several months, not, you know, a few weeks. You know, these started being studied back last summer. We finally got the approvals in December of this year. And again, there was dozens of thousands of individuals in the studies. I believe it was something around 36,000 or 40,000 in the studies. So they looked to see if anything major was occurring in terms of safety. And they looked at that efficacy data that we spoke about, 95%, 100% efficacy in reducing death. So they had that time frame. They went through all the FDA approvals. Obviously, it's approved under emergency use, but they still had to prove certain things. They had to prove safety. They had to prove the efficacy. And not only that, the FDA continues to watch these. So we're talking now about, you know, over 30 million vaccines have been given. All of those are being watched. And if we develop anything to indicate that these are not safe, they will pull it, as we've seen with Johnson & Johnson, and put them on hold. So I'd say that they've actually passed the test of this time at least. But again, going back to vaccine history, we find that most adverse events occur in those first 3 months. So we're already 9 months after the early stages of this vaccine being rolled out in the trials. We're already four or 5 months into the vaccine being given to the general public. And it's still, Moderna and Pfizer seem to be doing fairly well. And again, realize these are vaccines being given across the world. I know Israel has given out to a large part, over 50% of their population has gotten the Pfizer vaccine. And you're talking about, you know, 7-8 million people there. So throughout the world, you have a large number of these vaccines being given. If there's anything to indicate something comes up that's questionable, they will be put on hold. They will be investigated. And there's incentive to make sure these are safe and effective.
Okay, I got a question in the chat here. So this pertains to infection and how we contract COVID. Can you get infected just by someone's clothing and being in a close room with them? So I'll let you answer that, but there is obviously significant research about being in a close room with somebody, especially unmasked for a long period of time, over, I think it's over 10 minutes, that you're likely to be exposed. But I'll let you go with the answer on that.
Yeah, I think it's case by case. I think the CDC's recommendations now are if you're unmasked for 15 minutes within 6 feet of someone, you are at risk of contracting COVID and you need to isolate. Realize every case is different. You know, if you have a much closer contact with someone for 5 minutes, even though it's not 15, the likelihood of getting it is higher. Whereas, you know, if you're both masked and, you know, even if you spend an hour, but you're on other ends of a room, you may not contract it. And I think each one needs to be discussed individually. If anyone has a contact that they think is questionable, that's when you got to speak to your physician, see if it's something that requires a quarantine, requires any testing if you're having symptoms. But I do say it's very case by case. You know, the CDC has to put out very general sort of guidelines, but most contacts don't fall into a concrete, oh, yes, this is a close contact, or no, this is not. There's a lot of gray area where often you got to figure out if you need to quarantine or not. In terms of the clothing, I know early on, a lot of people thought clothing or groceries and things like that is where you can catch it. I think more and more we're realizing it's not from contact. Obviously, clean surfaces that might be contaminated. But in terms of clothes, you know, if someone puts clothes in a hamper and it's getting washed a day later, unlikely that anything is getting passed in that way. But still, to use some common sense, if there's an exposure and something was actually contacted by someone with COVID, try to avoid direct contact with those articles of clothing or anything else, at least immediately after they contacted it. You know, once it sits for a while, viruses don't live very long on objects. So they live long in individuals and people. So that's something to keep in mind. So, you know, no need to scrub the bottom of your shoes every time you get home with some alcohol and anything like that.
Okay. Last question. This one might be
Said that 3 times.
quite.
I'm just saying, but you got all the time in the world, Amy. You got me for the.
Yeah, I'm trying to take advantage of it. Okay, this one might be the most applicable question to our student athletes, their families, our staff. So suspicion, apprehension about the vaccine is common, particularly among disenfranchised communities in the United States. What can we do to ease these fears of our student athletes, of our coaches, of our family members who are saying, I don't trust the government, I don't trust, these vaccines, because communities have been through, lots of trauma involving things of this nature.
Yeah, I think the main thing is education. I think it's important for people to get educated and then go and educate the people around them. I think it's something that, unfortunately, you're right. Disenfranchised communities have gotten much harder hit with the virus itself. And some of that comes down to also educating on the importance of health. And I think, as student athletes, there's an important role we got to play to go home and make sure our families are living healthy lifestyles, getting to their doctors, getting regular checkups. I think these are important things. And, access to care is important, but that's also why it's important for us to promote good health, promote regular exercise, vitamin D, vitamin C. These are things that anyone can do at home. And these are important for people to realize we have to take care of ourselves. I think a lot of times we run into issues in deniers and people thinking that this isn't real, or, it's blown out of proportion, it's media. And certainly we have a component of, people incentivized for various reasons to push certain things. But we also have to realize that there really is a virus amongst us. It really does affect certain populations more than others, especially the elderly, especially those with underlying conditions. And those are the populations that it's most important to really get this vaccine. You look around, you see certain populations running to get the vaccine. And I think it's important to realize that we have safety and efficacy data on these vaccines. There is a reason the FDA goes through certain approvals with these vaccines. And we have to really break those barriers in our communities to make sure people understand this is what's going to keep us safe. And this is what's going to help, in a sense, level the playing field, because it's going to help those populations that are getting the most sick from the virus itself. And the sooner those populations get the vaccine, the sooner those populations can be healthier and moving on. And, unfortunately, I was working in Queens and Flushing, and our areas did get hit very hard. And I think we saw our hospitals getting overwhelmed last year. So part of these vaccines is going to help prevent that from happening again. And we want to keep those communities around us safe. So I really put it on the student athletes, not even for yourselves, but really for those around you. Go home, educate them, dispel some of those myths that people are talking about. There's a lot you see on social media. There's a lot you see on the media. And I think it's important to dispel a lot of what's out there that's fake news and make sure people are educated about how important these vaccines really are to prevent the virus.
So we talked a lot there about communities and making sure this is for the greater good. And that also applies to athletics. We can't have athletics safely unless we have developed some sort of herd immunity, which is what the vaccine is there for. So as student athletes, you also have a responsibility to protect everybody else, not just yourself. So, yep, agree completely. We do have one last question in the chat. Sorry, I did say that was the last one. Here it comes. So it's possible that a child who is asymptomatic can give the virus to someone even though after 2 weeks they tested negative for the virus. Vina, I'm assuming you're talking that the person who has contracted it has tested negative, or the child tested negative? Confused. I think she's in class.
So the person, okay, so let's just say like somebody came over and they were in the same room as someone else, and the person that was in the room with them got the virus, but that person was asymptomatic, and after 2 weeks of being quarantined, they tested negative. Does that make sense?
You know, we know they can infect somebody.
So you want to know if the person who was in the room with them can still have the virus
After being negative.
after the person tested negative for it, even though they're asymptomatic.
Yeah.
Okay.
I think it sounds like a very specific scenario. So I think it might be better we speak offline about the specifics of it. But in general, we say that, after 10 days of getting diagnosed, they're unlikely to be contagious. With severe illness, someone hospitalized, that extends out a little bit longer. But for, someone with a milder disease, we say by 10 days, they're no longer contagious, as long as they're not having fevers, as long as their cough is improving and their symptoms are improving. For a child, we talk about children and asymptomatic. It's unlikely that an asymptomatic child is going to be contagious for weeks and weeks and weeks. We still take that 10-day time frame, even though their contagious period is probably far less than that, especially if they're asymptomatic. In all likelihood, CDC says stay in 10 days. In all likelihood, it is a little bit shorter than that. But the CDC takes 10 days as kind of a precaution to make sure when people are coming out of isolation, they're really not contagious.
Okay, that's the last question, I promise. Thank you so much for this. It's been incredibly informative. I hope that the people who joined us on this definitely got something out of it, because I certainly did. If we have any further questions, you can also email me. I can pass on your questions to Dr. Nassim if I can't answer them myself. But yes, thank you very much, Dr. Nassim. Appreciate your time. And if there's any more further developments on the vaccine, we may have you back for a second session. But hopefully we will see you in our summer. Yeah, we'll hopefully see you in the summer for mass physicals, and we can get back to some sort of athletic schedule that we're all excited to be back. Okay, thanks everybody. Take care.
Take care.